All right, so let's talk about arrhythmias. So, an arrhythmia, time is tissue. So, ischemic injury can lead to damage to the heart. So, the more extensive this is, the more damage to the heart. It's important too for these arrhythmias to have rate control, anticoagulants, and rhythm control. Rate control can be due to metoprolol to help decrease heart rate, anticoagulants like warfarin, heparin, yeah, and rhythm control with amiodarone, even metoprolol sometimes. Arrhythmia is an irregular heartbeat. 60 to 100 is normal, and it's either irregular heartbeats are either too fast, too slow, or hella weird, just all over the place. It's caused by disruption in the heart electrical signals. It's affected by metabolic demands being increased, a cold or a fever, exercise, anxiety, panic attacks, fight or flight, sepsis, and shock. And if for electrical signals, it's due to coronary artery disease, heart failure, like we talked about earlier, previous MIs, a heart valve disorder, a light imbalance, let's say for let's say potassium, it's gonna F it up. Alcohol, drug use, toxins, right? Stimulants, CNS depressants, antihypertensives, stress and anxiety, obviously. You'll see signs and symptoms of palpitations, dizziness, lightheaded. So you're supposed to always monitor their vitals so they don't fall. Heart rate is important, obviously. Look at the rhythm. Is it regular or irregular? Blood pressure, SpO2, chest pain. They're going to have shortness of breath. Potentially, chest pain is very, very big for arrhythmias. Fatigue, syncope, obviously talked about. Weakness. Okay. So, types of arrhythmias out there are less than 60 if it's Brady. Problems, let's say, in the SA or AV node due to beta blockers, age, and heart disease. So if someone has a less than 60, hold the beta blockers because you can only give it if it's more than 60. Athletes can be less than 60 because it's just like that. And you have to check to see if the bradycardia is symptomatic or not. Make sure you put it in your mind, like, is everything that you're experiencing, let's say even AFib, is it symptomatic AFib or asymptomatic? Is it supraventricular tachycardia symptomatic or asymptomatic supraventricular tachycardia? Tachycardia is more than 100. You'll see a bunch of types of tachycardia in through these kind of different arrhythmias. So atrial fibrillation is an atrial problem. It's fibrillating, so it's rapid, irregular, a beat of the atria, and there's no P waves. Atrial flutter, similar to AFib, but the rhythm is more organized, but there's no P waves. You'll see a saw or a shark tooth, and you'll see like 3 P waves to 1 PQRS. So technically there's no true P wave. A supraventricular tachycardia is when there's a fast heart rate above the ventricles. You'll see them to be more than 140. Supraventricular, so fast heart rate above the ventricles. You don't see a PRT that great. You can also notice that the AFib and A-flutter can happen at the same time. A ventricular tachycardia, so supraventricular is above the ventricles. Ventricular tachycardia is the actual ventricles having a hard time. So anything ventricle related is a problem. It's life-threatening, a fast heart rate from the ventricles. It's fast, right? Anything fibrillation is when like things are going like too erratically. It's a medical emergency, and especially since it's your ventricle, it's going to be really bad because this is perfusing literally to your lungs and to your body. It's a medical emergency, it's hella fast, it's disorganized heart rate from ventricles, and you basically have an ineffective heartbeat in the end. So premature atrial contractions is early heartbeats. They're original from the atria. Premature ventricle contractions are early heartbeats that originate from the ventricles. You'll feel like an extra beat or a skip heartbeat. I don't think this is going to be on the exam, but it's good to know. Heart blocks, you'll see anything that's basically an AV block. So basically after it reaches the bundle of His. So, actually no, after it reaches from SA to AV. So after the AV, basically. The heart electrical signals are partially or completely blocked. So for the first AV block, you'll see your electrical signals are delayed. You'll see a long PR. So a PR is meant to be less than 2.0, right? 0.20, sorry. And you're just going to see a long amount of those. It's not like it's like irregular or anything, but it's just like long. You'll still have a QRS. AV block, second degree, you'll see some electrical signals don't reach the ventricles. You'll see a drop QRS. So you'll see in type 1. So second degree type 1 is when the PR is becoming longer and longer and longer. And then there is a predictable drop in the QRS. So eventually you'll see like, so if it's like, and then sorry, and you see a drop in the QRS. Type 2 is like basically you have consistent PR, so they're like basically like very good. They're less than 0.20, but then you have an unpredictable drop in the QRS. So long PR for type 1, lengthening PR and dropped QRS, and then type 2 is same PR, very normal PR, but unpredictable drop in the QRS. Third degree AV block is when the basically P waves and the QRSs are not synchronized at all. They don't give a shit about each other. They're doing their own thing. You need a pacemaker for this. You'll have complete blockage of signals. Yeah, very important to get into the bottom of that. I should just go into the ECG a little bit. So before I do anything, just want to mention that sinus rhythm is basically the cardiac conduction system. It goes from the autonomic nervous system. So basically, the autonomic nervous system is here. And you'll see that it being the PNS and the SNS, so rest and digest, and SNS, so fight or flight. So PNS is like inhibitory, anything inhibitory. So lowers the heart rate, cholinergic nerves, use of acetylcholine, beta blockers. You notice this for like, let's say, the refractory period of action potential. You can let me think about that. Fight or flight is like the SNS, the excitatory, the heart rate is increased, the adrenergic nerves like beta receptors use catecholines like norepinephrine, epinephrine, dopamine. You'll see atropine given. It suppresses basically the act of this. Basically helps to increase the heart rate. And then beta 2 agonist. So basically, if you see here, beta 2 agonist. So beta 2 works on, let's say, the lungs, right? It does work on the heart, but also the lungs. It dilates bronchioles, lets more air in, dilates smooth muscle, so vasodilation. And basically, same thing for the heart. It will do the same thing by dilating and causing a decrease. So, beta 2 antagonist constricts bronchioles, doesn't increase air entry, doesn't allow air entry, constricts smooth muscle arteries. So basically sympathetic receptors, so beta 2, beta 1, and alpha. These are all sympathetic receptors, and there's meds to manage arrhythmias, either stimulate an agonist or block the SNS, so antagonist. So anything stimulating you'll see as an agonist, and anything blocking will be antagonist. So you'll see alpha 1 and smooth muscles in the arteries. Alpha 1 agonist basically help with the SNS, so they release norepinephrine, they vasoconstrict, increase blood pressure. Antagonists do the opposite, they vasodilate and then decrease blood pressure. Again, it has to deal with the sympathetic nervous system. If it's an agonist, it stimulates, and if it's antagonist, it will block. So if it's an agonist, it will increase blood pressure, basically the effects of the SNS. And if it's antagonist, it does the opposite of the SNS, antagonizes the SNS. Beta 1 are working on the cardiomyocytes and kidneys. So you'll see an agonist increases contractility, increases heart rate, increases renin release, basically does all the sympathetic stuff. But if you're doing a beta blocker, you're blocking this shit. So you're doing a beta antagonist. Beta 1 antagonist is a beta blocker to help reduce contractility, heart rate. You'll see metoprolol like we talked about, bisoprolol. Metoprolol is selective, so that's good. It works specifically on the heart and the kidneys. Bisoprolol, another thing, gives the heart more time to fill, which increases cardiac output. So bisoprolol and metoprolol, very important because it gives the heart time more time for the heart to heal to increase cardiac output. We talked about beta 2 already, but beta 2 specifically works on the lungs. If it's an agonist, it basically helps for the SNS. If it's an antagonist, it basically does the opposite for the SNS. Now looking at science rhythm, the cardiac conduction system, very important. From the autonomic nervous system, either if it's going too fast, that means the SNS is fired up, like a lot of activity in the SNS. A lot of agonists happening on the SNS. But if it's super slow down, that means the penis is hella activated. Okay, so you'll see how it starts from the SA node, where it has a beta 60 to 100, which is the natural pacemaker of the heart. Pacemakers are implanted when heart rate is low or SA node does not work. So let's say if someone has a 40 to 60 and they're at the AV, and because the SA failed on them, they had to have a pacemaker implanted because you can't just live off a 40 to 60 heart rate. It's natural pacemaker of the heart, initiates beats and determines the heart rate. Ion channels most gens here, so action potentials fire hella here. Then it goes to the AV. Then basically atrioventricular node, it has a heartbeat of 40 to 60. It's a backup when the SA node isn't working. It delays electrical impulses to the ventricles. Therefore, atria don't have enough time to eject all the blood into the ventricle before ventricle can contract. It delays electrical impulses to the ventricles, basically. So atria can have enough time to eject all the blood into the ventricles before they can contract. So this is a delay. The delay. So then they can eject everything here. Then it goes from the AV to the bundle of His, then to the Purkinje fibers. Purkinje fibers have a heart rate of 20 to 40 because they have ventricles, right? More tissue, more mass to actually pump. If you have heart hypertrophy, it is because it is due to remodeling. We talked about this a little earlier. A bigger heart with thicker muscle, but it's not enough. It still has it doesn't have enough space. Dilation is when the heart is big with a lot of big space, but the muscle itself is thin. So dilation is different. It's almost like a balloon. And then hypertrophy is like a thick ass, beefy ass muscle. Now, ECGs. An ECG. So basically, in the SNS, you'll see a heart rate increase and a penis heart rate decrease, and the ECG depends on those things. A second and fifth lead is easy to read because it lines up with the heart. It's electrical activity of the heart, so not the pumping or filling of the heart. That has nothing to do with ECGs. ECGs, very important. Shows all action potentials produced by the nodes, not in cells of myocardium. A PQRST equals 1 heartbeat. And so you'll see that 5 boxes equals 1 second, 30 boxes equals a 6-second strip, and heart rate is measured by an R to R. So yeah, let's start with the P. So the P is basically, you won't be able to see it in AFib or A-flutter or even SVT, even ventricular tachycardia sometimes. So basically, you see the atria depolarize here. So basically, sodium channels are dense here. The SA node is firing. Sodium enters the cell, so it's more negative to allow the action potential to happen. So it's more positive. Positive becomes more action potential. Depolarization has to happen before contraction. So basically the P is a little wave of atria that are depolarizing. And it's sinus rhythm. P shows sinus rhythm. Atria contracting and the PR, not too important. But the QRS complex, very important because it shows the ventricles depolarizing. When the ventricles depolarize, atria repolarize. QRS complex is big because the amplitude is bigger because there's ventricles, so there's more tissue to be excitable. If you have left ventricular hypertrophy, you'll notice that the amplitude is hella big. QRS is like the AV node fires here. So atria and the ventricular. So basically ventricles depolarize. Atria repolarization. So basically happens to be back to the original state. ST is the Purkinje fibers. AV node is here. Ventricles contract in the ST. Blood is pumped. And the T is very important. It's a little bit is fine. But the ST segment shows like an MI. If it's ST elevated, it's a STEMI. If it's a N STEMI, it's a non-ST elevation. So, yeah, very important to look at the ST segment if someone has an MI. When the T wave is peaked, that means there is hyperkalemia. So very important for someone that has a fluid imbalance, or potentially that could lead to cardiac arrhythmias. So very important to check this out for T waves. T waves, hyperkalemia. A U wave, not really important, but hypo. If you're going high, I'm going to go high. So T wave is when ventricles repolarize. So P is when atria depolarize. SA nodes fired. QRS is when ventricles are depolarizing and atria repolarizes and AV nodes are firing. And then the ST is no big deal, but it shows the heart attacks. And then the T wave is showing the ventricles are repolarizing. So yeah, it happens right before ventricular relaxation. So PR shows the atria contractions. So if you have a lengthening PR, that's a problem for all the blocks. That means there's a problem for blocks. AV blocks are more so the PR. PR is here, which is called a PQ really. Potassium efflux state, sodium cancel, slows down. Okay. So you can get 4 causes of arrhythmias, one or both of the combos. So abnormal rhythmicity of the pacemaker. So let's say the SA node is firing so fast or so slow. So either sinus brady or sinus tachy, or it's just being hella weird, like atrial fibrillation. So you'll see like an increased automaticity. So careful of hypokalemia. So basically automaticity is just like the automaticness of things. So you'll have a high SNS activity, so epinephrine or epinephrine catecholamines. You'll have low vasal activity, drug-induced like quinidine. Increased automaticity. Action potential is reaching threshold faster and not enough time to repolarize, so just completely just like too much stimulation. A lot of stimulation to the heart. A lot of firing. Automaticity causes arrhythmias due to the increased rate of cells depolarizing. Its ability for the cardiac cells in the SA node to spontaneously depolarize and generate electrical impulses without external stimulation. So you're basically sitting at home or sitting in a cafe, and then out of nowhere, like your heart just goes da-da-da-da-da-da. That's a lot. Increased automaticity due to pacemaker cells depolarizing more rapidly and triggering premature extra heartbeats. Basically, increased automaticity can lead to premature atrial or ventricular contraction. So we talked about that. PVCs or PACs. SNS activity is increased, so stress, anxiety, exercise, that can happen. So you can have like automaticity, or arrhythmia, or you'll feel like your chest pain after exercise. Electrolyte imbalances, so hypokalemia, meds like beta agonist, beta agonists help to do the SNS activity. Increased vagal activity, ischemia, lowers blood flow to the heart tissue. And you also see it here as well. The 40 is a negative threshold. Normal atomicity is like basically just going from here to here, the ventricle depolarization. And then it goes back here. When repolarization, potassium flows out of cell. And then it goes up, but increased atomicity is because action potential is reached threshold faster and not have time to repolarize. So just going in. It's not even going into the deep parts where it should be to relax. So there's meds to lower the threshold, so don't need to have so much charge to generate an action potential. So I wonder if that's like better protocol. Secondary to SNS stimulation, like a lot, or exercise and drugs. Another thing is another cause of an arrhythmia is when the pacemaker is not from the SA. So if it's not from the SA, it's from the AV probably. Or yeah, it's from the outsides of the part. So a spontaneous generation of impulses in almost any part of the heart, I guess. So it's ectopic. Ectopic means outside of our normal tissue. And it causes arrhythmias. So basically you'll see sinus node arrhythmias like a regular sinus node arrhythmias, so it's sinus brady, so it's regular, but just too fast or too slow. So sinus brady, sinus tachy, and a sinus arrhythmia. Atrial arrhythmia is when there's a P wave problem. So the atria arrhythmia is when there is a P wave problem. Atrial fibrillation, AFib, so anything atria related is basically the P wave, because like their atria is when the atria depolarize, right? So multiple ways, crowd of people trying to yell at AV node to beat. A flutter is one or two areas trying to, okay. Junctional arrhythmias, you start the AV and our blocks, so basically all the blocks here, junctional. AV bundles affected, there's a QRS problem, so QRS is the ventricles, because of AV, atrial ventricle. First degree, there's PR is long and consistent, so there's long, more than 0.2, more than 0.2, more than 0.2, more than 0.2. And has a sinus rhythm, but has a conduction delay, so you just have a conduction delay. A second degree is a drop in QRS somehow. AV node's not working. So type 1 would be like a predictable PR lengthening, but a predictable drop. Type 2 is like PR just continues to be the same, but it's an unpredictable QRS drop. Type 3 is a complete dissociation between P and QRSs. Ventricular arrhythmias are life-threatening because ventricles control all cardiac output. So VTAC, pulseless defibrillator. So if it's VTAC and if it's pulseless, then use a defibrillator. So defib when it's VFib, or pulseless VTAC. VTib for defib, but asystole, you can't shock, you have to do CPR to make sure you get a rhythm first. Abnormal pathways of impulse transmission, also another reason for arrhythmia. So let's say something that other than the SI node and AV node are running the show, basically. There's reentry circuits. Just abnormal pathways of impulse transmission causes arrhythmias. Reentry circuits, so impulse re-enters and reactivates the originally stimulated muscle that is not refractory anymore. Causes AFib, VFib, VTAC. Is not part of the SA or AV path, but can be congenital or formed. It happens when the conduction is slow. Electric signals just naturally follow the path of least resistance, so conducts to any tissue that is at rest. So let's say the atria had a slow conduction already, but because of the slow, like the atria had a slow conduction going down, so because it had a slow conduction going down, it just kind of goes back up and causes arrhythmias. Has less conductive ability, waits on bridge and moves slowly, gets to the AV node. Basically, it goes back to the point of OG and of the heart, listens to reentry message and acts too quick. You'll get a flutter, takes back road, constantly moving just to end up back where you started. Reentry circuits are electrical impulses re-enter and continue circulating in the heart, repeated activation of the heart. If there is a block or delay in normal conduction pathway, impulses find other route to re-enter OG tissue, creating circular electrical pathway and lead to heart firing fast and repetitively. Common cause of supraventricular tachycardia is AFib, aflutter, ventricular tachycardia, and ventricular fibrillation. It causes arrhythmias due to allowing electrical impulses to recycle through the heart tissue and create sustained abnormal heart rhythms. The impulse re-enters and reactivates originally stimulated muscle, which is no longer in refractory period, and increases the heart rate as a compensatory mechanism. You won't see any Brady's here, as you noticed. Re-entry occurs if there's a long-ass pathway. It just goes back due to a dilated heart. Lower rate of conduction, so let's say the Purkinje system is blocked. There's ischemia, and there's hyperkalemia, so there's a lot more action potentials that are fired. So the AP is delayed. Action potential is delayed. It means it's not reaching refractory. Shortened refractory, so it just goes here, but then before even staying here as long as it should, it just goes fires again. Usually due to epinephrine, too much stimulation. End result of reentry is too much stimulation. So even for here, you'll see that it's automaticity, it's too much stimulation. And then pacemaker, not from SA, as in like it's just ectopic, so just random stimulation. Again, too much stimulation. And then electrical blocks at different points of the pacemaker path that stop electrical delay. So reduced rate of conduction due to the Purkinje is blocked. And muscle ischemia. Low blood flow due to ischemia or previous MR scar tissue equals lack of ATP to generate action potential, blockage of Purkinje system. This is more of like an ischemic issue. Very good. Now, a little bit about AFib. So AFib is atrial fibrillation. Pacemaker is not from the sinus node. It's having a hard time to basically have a heart rate. And normal pathways of impulse transmission through the heart affects both the atria. You get atria quiver, clots because not bleeding, not being contracted forward, so there's no atrial kick. You get strokes, high risk of strokes. You don't want the heart rate to be too fast because heart already stressed, so you need meds like metoprolol. Loss of atrial kick to push blood forward. If the heart's dilated, you'll see that the BNP increases, which worsens heart failure. Stretch. Collecting chambers of the body, electric signals help push body blood from atria to ventricles. But AFib, these are fast, irregular. So atrial fibrillation is irregular. It's unorganized and ineffective pumping of the blood. So sustained arrhythmia, disorganized atrial electric activity is atria problem. So atria is atria problem, atrial fibrillation. And contraction, so you're not ineffectively pumping blood out. When controlling SA and AV node activity, adrenaline activation is altered by sodium-calcium influx, potassium influx, and sodium-potassium pump. So if you have a sodium-potassium pump, it either lengthens the action potential or speeds it up. As in, like, it slows down by lengthening the action potential. So it'll be like, and then speed up, or it can speed up by going like, that's the action potential, so it's firing like hell. Irregular, like I mentioned, RR measurements are irregular. AFib is not like sinus tachycardia. It's organized and fast for sinus tachycardia because it's irregular. AFib is either too fast or too slow or disorganized, irregular. It doesn't have any P waves. It doesn't have an isoelectric line. We don't really care about that at this point. It's irregular. There's squiggly lines, but QRS complex is visible. But this P waves are not it because it's an atria problem. Variable ventricular rate, so it's tachy at 110 to 60s. Bradyia at less than 60. So if it's like this, that means it's uncontrolled. Uncontrolled, if it's more, it's at 110. Not 100, 110. There is a low cardiac output resulting in, I wouldn't say an increase, but a decrease in blood pressure. Patient becomes symptomatic when ventricular rate becomes too rapid. There's cardiac glycosides like digoxin or positive inotropes that are given for uncontrolled AFib. So digoxin basically lowers heart rate. To increase contractility increases cardiac output because heart rate is unreliable. Atrial fibrillation is caused by heart disease, hypertension like pulmonary hypertension, valvular heart disease. CHF can cause AFib and vice versa. So CHF can cause AFib and AFib can cause CHF. Acute infections, electrolyte imbalance, like let's say CKD, you have too much calcium, that's going to F up the situation in your heart. Hypokalemia and hypomagnesemia also is a problem. Heart's reentry pathway from potassium and glucose shifts causing scarring. You also can see that with alcohol and drugs, sympathomatics. Pulmonary embolism, hypothermia, digoxin toxicity, diabetes, sugar hurts basement membrane causes a scarring, increases hypertension, causes more problems, weight, sleep apnea, high lipid count, and it being over 65, it leads to hemodynamic instability, heart failure, cardiomyopathy, embolic events like stroke, and ischemia, TIA. You get sick sinus rhythm syndrome, aka sinus node dysfunction. So sinus node dysfunction, aka sick sinus syndrome, which is a P wave problem, which is an atrial problem. Your first episode is when the AFib is detected. Recurrent AFib is more than 2 episodes. Paroxysmal AFib is like self-terminating, less than 7 days. But basically, if it has to be more than 48 hours, but less than 78 days, you're more not likely to go back to sinus rhythm, but you need anticoagulant. Persistent AFib is more than 7 days. Long-standing is basically a year, and then permanent is more than a year. So it goes from first episode, a reoccurrent with more than 2. Paroxysmal is more than 48 hours, less than 7 days. Persistent is not self-terminating, but more than 7 days. You need something to get out of this. There's a lot of occult risk and stroke risk. Long-standing is a year. It's chronic, difficult to treat, permanent. You can't do much to get out of AFib. Signs and symptoms, asymptomatic only. Make sure you understand that, Mazian. Palpitations, you'll see heart racing irregularly, flip-flop in the chest, irregular to AV nodes, sending impulses, heart rate shifts from 150 to 180. Urinate if you're tired, you don't have energy, you have fatigue, you have weakness, shortness of breath on exertion. It's because your heart, you can't move, you can't have a forward flow of blood to the lungs. Because the atria is backing everything up, the lungs not able to get anything. So you have shortness of breath, chest pain, lower pulmonary perfusion, heart tissue not getting any oxygen, coronary arteries and aorta are blocked, causing chest pain due to not enough blood flow to heart muscles or mild ischemia. Lightheaded, not enough, because the cardiac output is decreased to the brain, then perfusion is also decreased, so causing anxious, dizziness, lightiness, trouble concentrating, impaired reflexes, proprioception, impaired balance, tachycardia. So yeah, treatment for AFib. First, you want to get the rate under control. You want to do rate and rhythm control to reduce the heart rate, so you give beta blockers, calcium channel blockers. Then you would do rhythm control. You do cardioversion, shock to restore normal rhythm, get them out of AFib to be able to control heart rate. Antiarrhythmics, basically to this, amiodarone, digoxin, cardiac glycoside, anticoagulant. You'll use DOACs, direct oral anticoagulants, warfarin, anticoagulant. Aspirin is an antiplatelet. Clopidogrel. Balance between risk of stroke and bleeding, very important, but cardiac output has to be prioritized. Bridging with warfarin, so basically you bridge with heparin until you need to use warfarin as a long-term use. Aspirin and antiplatelet, so if someone has bleeding risks, you should hold it. So let's say someone has kidney situations, liver situations, you might have to hold it. Treat underlying cause, last resort, electrophysiology study and catheter ablation, so a scar formed to stabilize electrical shortcuts. You have to decrease your weight, diabetes, stress management, alcohol use, diet, no smoking, exercise. Treat underlying cause can help a patient get out of asymptomatic AFib and convert to normal sinus rhythm on their own. Direct oral anticoagulants, you'll see the Abans, rivaroxaban, apixaban. There's no reversing agent, so you need to be natural. This one is a problem because you have to flush out your system, and you only use it if warfarin's not working for you anymore. Cardioversion is like TE to check for thrombus clot before cardioversion, and then given shock to put back in normal sinus rhythm. So cardioversion is basically a defib, but also a shock, aka all of these three are the same. Ablation, so you burn re-entry pathway on heart tissue and get conduction back to rhythm of SA node. The goal of treating AFib is to have rate control first. So pacemaker and meds like metoprolol, all the lols, even Ramipril. If someone has heart failure, it can help with both. Anticoagulation, so warfarin bridging takes 5 days to start working. Therefore, IV heparin works fast to bust clot, then can start on warfarin. Increase enoxaparin dose based on weight. DOAC they use last because of the non-reversing agent part. Rhythm control, cardioversion helps conduction, and ablation therapy. In this thing, you'll see the types of medications. So OLOLs are going to help with the rate. So sodium influxes, so it will come and prevent too much action potential, the rate. Platysm, cardiazem, calcium channel blockers, so they'll block calcium, and so not as much of like an action potential lengthening. And so sodium channel closed when it's positive, so obviously this is when ventricles are contracting, or when ventricles are depolarized. Adenosine used to stop depolarization and repolarization for 15 seconds, so basically gives you a reset time. Reset right here. Amiodarone basically is antiarrhythmic, so basically helps with like controlling the rhythm. Sodium potassium pumpase shoves sodium back out of the cell, potassium back into the cell with help of ATP. Sodiatoxin is a cardiac glycoside. It helps calcium stay in heart longer action potential, more contraction. Yep. Desired result, action potential takes longer to complete. Therefore, it gives ANS a chance to signal SAAV node at a reasonable rate and helps improve cardiac output by allowing more filling. So you want the action potential to be longer, not AFib, where it's like hella random and everywhere. You want it to be a little longer, so then the autonomic nervous system can signal the SA and AV node to like chill out. Now let's do some ECG related stuff. Ouch. Make sure you know if it's stable or unstable. Normal, regular rhythm, resolved stimulus, short in duration, electrolyte imbalance, hypokalemia, hypomagnesemia. So yeah, if it's before the SA node, it is an atrial problem. Between the SA and AV, if you're somewhere, it's an atrial problem. After the AV, after the QRS complex, is a ventricle problem. Alright, here you'll see A flutter. A flutter, you'll see regular R to R's, so R to R regular. No sinus because no true P wave. Sinus is only if it's from the SA node. You see there's no true P waves. There's 3 P waves with 1 QRS and it's like a sawtooth, aka like a chainsaw or a shark tooth. But the R's are regular. That's A flutter. I'll look for AFib now. AFib, yeah, it has to be between 60 to 100 to be controlled. It's irregularly irregular, and there's no true wave, just like the A flutter. You'll see premature ventricular contractions, inverted wide QRSs. A wide QRSs is more than 0.12 PVC, premature ventricular contractions. And now let's look for this is artifact. It's like literally when everything is going everywhere, you don't know what the frick is going on. Shakiness, poor lead placement, normal sinus rhythm. Apparently, is this P wave? You can see a QRS, you can see a peak T. The T looks kind of big, but we'll see. I don't know. Sinus bradycardia. You see the R to R's are far away from each other, but technically it's a regular rhythm. Let's look for tachy. So yeah, ventricular tachycardia. Is basically you have to call a code for this person because of the ventricle problem. Dangerous. Anything ventricular tachycardia or ventricular fibrillation, you might have to call a code because ventricular tachycardia can lead to a VFib eventually. You technically don't have a rate. You'll see 3 tombstones. Right? This is a tombstone looking thing. Ventricular tachycardia. So ventricles. These are 3 PVCs in a row equals ventricular tachycardia. So 3 of these. You'll see wide QRSs, tombstones. Originates in the ventricle, it's dangerous. Now, ventricular fibrillation. Ooh, very bad. You'll see it looks like kind of crazy. No QRS, no P waves. No regularity. It's irregular. Low amplitude. It's just like trying its best to stay alive. You need to shock this. VFib, DFib, Laha says. And then pulseless ventricular tachycardia is when you defib as well. I think I talked about AFib. Let's look at the asystole is like you can't shock, you need to do CPR. Let's do the block. So first degree AV block is you'll see how the PRs are like long. Technically the PR has to be 0.12 to 0.2, but the PR is actually more than 0.2. So you'll see it measured 0.2, 0.2, 0.2, 0.2. And the QRSs are narrow. Conduction delay between SA and AV. Between SA and AV. Yeah. There's a conduction delay between the SA and AV because the PR is a problem. SA is a P wave because it's like the SA node, and the AV node is the QRS start, and that's when ventricles are up there. Second degree is a QRS problem, right? So second degree type 1 is like lengthening PRs and then random drop in QRS. So look, PR, lengthening, and then technically there was no QRS. AV node not getting anything. AV bundle block here. SA is firing but not getting through to AV basically. Now second degree type 2 is this one. 60 heart rate. There's a consistent PR, like you'll see how there's a PR, I guess. PR, always a PR. But the thing is, there's no QRSs, like it's unpredictable drop of QRSs. While second degree type 1, you can see like a predictable drop. Third degree, where are you? Third degree. Huh, I guess there's no third degree. Oh, never mind, here. Third degree AV block is lead 2, lead 5. You can see that there's no synchronization between P waves and QRSs. So this is a P, I guess. This is a QRS. But there's a P now doing its thing. And then there's a delay now, but there's also a QRS doing its thing. QRS is this thing like we're literally whenever. And then here, a little bit into everything. So a normal QRS has to be dealing with the ventricles. Is usually less than 0.12. You want it to be narrow. A wide is when there's a delay, right? If a normal PR is a atria thing, interval is supposed to be less than 0.2. First degree AV block, let's say you'll see a PR is more than 0.2, and you'll see that's a delay. Any kind of blocks or delays. Okay, normal sinus rhythm, we know obviously what it is. PQRS is there, T is there, and then it's between 60 to 100. And it's regular R to Rs. Now, supraventricular tachycardia, it is above the bundle of His, above the ventricles, supraventricular. It's a narrow QRS. And ventricles are pumping hella fast. And there's no real treatment technically. You don't see a P, you don't see a T, heart rate's more than 140. And then some things about this is that you'll see a flutter sometimes and AFib. So all of these ones, you may not see a P wave. Mostly these ones you won't see a P wave for sure, but even this one potentially. So a flutter is basically the 3 P waves to 1 QRSs. Re-entry or circuits are in the atria, and then you have like a hella fast heartbeat, like 300. Beta blockers are given to decrease the rate. Calcium channel blockers are given for cardioversion. And AFib, you have to do a rate rhythm control for both, right? So they both have a regular, there's a regular QRS for a flutter because it's part of that, right? AFib, we don't see any of that shit. There's a narrow QRS because the ventricles are trying so much to cooperate. And AFib, you'll see is only controlled at 60 to 100. Both of these things uncontrolled leads to low cardiac output, therefore low blood pressure. You get dizzy, weak, confused, chest pain, shortness of breath, palpitations, tachycardic. You need to use amiodarone, maybe, potentially, for rhythm control. Rate control, you do that with metoprolol. Anticoagulant with warfarin. Calcium channel blockers if you need. Yep. And you can treat the supraventricular tachycardia with a vagal maneuver or adenosine. I think vagal, right? Canadine I saw. Increase vagal activity here as well to help reduce heart rate. Remember, like where you hold your breath basically and try to bear down? I think that's what it is. Okay, I'll come back to the meds over there. So then, yeah, that's pretty much studying bradycardia. You have to see if it's symptomatic or not. You use a pacemaker, atropine, EpiPen, or epinephrine. Athletes can have a sinus brady, sinus tachy, beta blocker, calcium channel blocker, fever, anxiety. Monitor fluids if the person is dehydrated, because that can cause tachycardia. Treat underlying cause like increased metabolic demand, cold, fever. So tachy, basically someone's just tachy, like they're just heart rate, and this person is low heart rate. Exercise anxiety, panic attacks, septic shock, ventricular tachycardia is just high heart rate in the ventricles. But this is a problem because defib for VFib or pulseless VTAC can have no P waves. There's stable or unstable. There is unstable, which is pulseless, and each defib, and called a cold blue. Ventricular tachycardia is the tombstone looking things that we saw earlier. Here. First degree AV block is, we talked about this, PR being more than a 0.2. Second degree, longer, predictable drop. Type 2 is PR constant but random drop. QR, always check the patient before anything. Call a code blue for VFib. Maybe even ventricular tachycardia. Asystole needs a code blue as well, because no shockable, needs CPR and epi. Meds in general, good to know. So amiodarone, antiarrhythmic, controller can corrects abnormal rhythm. Metoprolol is a beta blocker, activates the PNS basically. It is a antagonist and slows the signals between SA and AV, slows down heart rate and contractility, and prevents renin release. A hold if heart rate is increased or blood pressure is too low. Even if it's a good heart rate, you have to check the blood pressure too. Diazepam is a calcium channel blocker. It delays action potentials and controls the rate. Warfarin. So diazepam, calcium, potassium, calcium, diltiazem. Warfarin, anticoagulant, prevents blood clots and strokes. INR has to be 2 to 3. You have to always make sure blood work is done. Apixaban is an anticoagulant, prevents blood clots and strokes, so be careful if it is beginning with someone that has CKD or liver problems. Synchronized cardioversion, electric shock delivered to the heart to reset abnormal rhythm for VFib, defib, pulseless VTAC, back to normal, used for AFib and A-flutter as well. Ablation therapy, I know this, used for SVT and ventricular arrhythmias. Pacemaker, implant under the skin to maintain normal heart rate for heart blocks and bradycardic patients. Pacemaker. Implantable cardioverter, defibrillator, implanted device into the chest, monitors heart rhythms and delivers shock, and life-threatening VTAC or VFib detected. That's nice. Lifestyle changes, change how much you drink, don't drink enough caffeine. The stimulant drugs, don't do it. Manage stress, weight, diet, activity, treat underlying conditions, hypertension, diabetes, thyroid disorders. And that is everything.